call the meeting to order. The secretary will take roll silently. Senators will be excused until they arrive. And minutes are approved as of the last committee that we had of April 20th. Any objections to the meeting minutes from April 20th? All right, seeing none, we'll progress. We're live streaming today's meeting, and the DHS handouts are posted on the live streaming site. This morning, I'd like to thank all of you for coming to this very important meeting today. This is the one meeting that the Senate Human Resources Committee is able to have out of session. And so we chose this date so that we could analyze some data, so we could take a look at some of the data that's been collected since April 1st, and it is after the July 1st period. What I'd like to make sure that we do today, I've set out some goals. So to get a global view of how the system is working or failing, this transition, find out why there are problems surrounding pre-authorization, billing, and reimbursement. And please silence your phones if you can. Number 3, work toward resolution in regard to pre-authorization, billing, and reimbursement. And hear from providers and consumers, our constituents, about the transition and pose these issues to DHS and to the MCOs in a productive way. So I look forward to the results of this meeting today. We'll do this in 3 different parts. We have at 10:15, we'll have Medicaid privatization implementation report by IME. Then at 11 o'clock, we'll hear from the providers. We have the 3 MCOs the providers from different places across the state. At about 11:45, we'll take a lunch break. At 12:30, we'll be back and hear from consumers and advocates. At 1:15, the MCOs and DHS and IME will return to the table, and we'll talk about what we've heard throughout the day and then go to some of these global questions. And then we'll have closing comments about 2:25. Now, I know that some people have to leave and go to other meetings, and we want to make sure that we're respectful of those time frames. I'd also like to this morning welcome Mark Costello, Senator Costello, who is now the ranking member from the GOP, and also Jack Whitver, Senator Jack Whitver, who is here and a new member of the Human Resources Committee. So welcome, Jack. Let's begin with the Medicaid privatization implementation report and welcome Mikki Stier, our Medicaid director, and Liz Matney, the Medicaid Managed Care Bureau Chief, to the table, if you will. Good morning. Do either of you have some opening statements that you'd like to make?
Yes, we have an opening statement. Yes, we have an opening statement. Thank you. I gotta flip this around. Good morning, and thank you for this opportunity to talk about Iowa's transition to managed care. We're pleased to present some initial reports and data to you today. Over time, this information will grow, and we'll be able to provide further analysis and trend information on how managed care is meeting the state's goals, which is to improve patient access and quality of care, promote accountability of patient outcomes, and create a more predictable and sustainable Medicaid budget. While no major healthcare transition, especially one involving more than 500,000 people, can go perfectly, we are confident that members have been able to access the services they depend on, and a majority of our providers are being paid. Any system issues are being addressed to ensure that accurate, up-to-date information is available. There are still challenges in change of this magnitude, but we are able to meet the member and provider concerns when they contact us and address those issues and make necessary changes. Some of you at this table have contacted IME, and we worked very hard to respond to every one of you. We want to hear from Iowans who participate in the Medicaid program, and their feedback is crucial, and we continue to hold monthly meetings across the state to hear from them. So, We are now 116 days into this transition, and today I'm going to provide reports and updates, and I'd like your partners with managed care organizations, or the MCOs, to also hear and speak about their successes and challenges as well. While we have oversight of the program in Iowa Medicaid, they're providing the coverage and can give a comprehensive picture of the first several months of this transition. I hope you'll allow them to join me at the table and add their perspective. Before I ask them to share their thoughts, let's go through some of the reports that are available. And as you said, they're available on YouTube, but they're also available on the DHS website under Recent News. But first, I want to thank the providers. They are dedicated to Iowans and help ensure Medicaid members get the care they need to be healthier. Health plans need a wide variety of providers to ensure that they have adequate networks, and we want to work collaboratively to continue these provider relationships that the state Medicaid members depend on. Many of our providers are used to billing commercial plans in a similar manner to what our health plans require, but those new to it, including many of our long-term care providers, have new administrative challenges. The goal going forward is to make a more efficient program that ensures quality delivery of services to our members. Systems are now more automated, and the majority of the rejections, suspensions, and denials are happening because of claim filing errors, such as not putting identifier numbers, missing signatures, but we're here to help. Provider issues that may impact members are escalated rapidly to our rapid response teams. Any system programming issues that are identified are addressed as quickly as possible and ensure appropriate payment to our providers. The new health plans have state-of-the-art systems that follow industry standards and how many other state Medicaid programs operate. These systems had to be programmed to meet the unique requirement of Iowa and our provider rates that support our providers. So, while we know that learning these systems can be difficult, these challenges under managed care create a more efficient system that ensures care is delivered to members and that providers are reimbursed appropriately for medically necessary services. This is important, as this program has doubled in cost over the past decade or so. It will help make a more sustainable program that will continue to support the members with all types of services they depend on. Most providers are used to billing multiple commercial insurances and use clearinghouse that help them catch those errors. There is various software available, including free or at a nominal fee, to help providers process claims filing go more smoothly. Again, we're here to help. We've provided a dozen of provider trainings that were held across Iowa, and we're launching additional training across the state with our MCO partners starting in August. There is a billing sheet in front of you that I'd like to call attention to, please. It looks like this. We've processed over $3.4 million in claims paid to Iowa Medicaid providers since April 1st. The claims have been paid on an average of 8.5 days, 40% faster than in the MCO contracts. Similar to fee-for-service, the average day of payment is 7 to 10 days, and the MCOs are contractually required to pay 90% of clean claims within 14 days and 99.5% within 21 days. The state withholds a percentage of payment until this requirement is met. MCOs have a modern computerization system that verifies claims to ensure accuracy and prevent fraud, waste, and abuse, and it creates a more efficient system. All claims, forms, and formats, as we have discussed earlier, have been moved and utilize the Iowa Medicaid program. Iowa Medicaid and the MCOs have worked to respond to issues. And there's a graph that can show you between each of the plans, and I'll let them speak to that, in terms of total reimbursement of about $99.3 million has been paid out. You can see claims submitted of $4.9 million, claims paid 3.4, claims denied of $1.2 million, and claims suspended about 300,000, and total rejected is about 100,000 claims. Most common reason for a denial on a claim is duplicative. Our providers are sending in multiple claims for the same payment. The services are not part of the Medicaid program, and the primary insurance coverage needed to be billed first. And the most common reason for denials is necessary information is missing, as I've said before, invalid service dates, and the provider isn't enrolled in Medicaid. But we are paying all legitimate claims that are presented to the MCOs for payment. I'd like to introduce the monthly reports. While other states with managed care programs produce only a quarterly or annual report, the Iowa Health Link program is focused on providing regular, meaningful, and transparent information to assist Iowans. Our legislation requires quarterly and annually. So the monthly reports, I will defer to Liz Matney to review with you, but they focus on the demographics of the managed care population, changes in enrollment, such as members switching to MCOs, compliance information for member services getting services such as prior auths, providing paid claims and reimbursement, network adequacy, historical utilization, and they identify compliance issues which we will further evaluate and take action. And in addition, the monthly report for month one is available 45 days following the end of the month. So for example, in August, it would be available October 15th. So if you will, Madam Chair, Liz Matney can walk you through the monthly report.
Thank you for the opportunity to share some data with you. As you all are aware, the quarterly report is what is required as part of the legislative oversight bill, and we will be publishing that shortly. So we just have been receiving the quarterly data at the end of this month, and we need about 30 days to process that and analyze it. So for the month of April, you should have both April and May in front of you. We have the monthly reports available just to show some key demographics, performance indicators, as well as to continue to share the CMS historical utilization report that CMS required as part of this transition. So we open it up. Page 3 is where we really start to get some data on demographics. We start by showing how the managed care enrollment is spread across our 3 primary programs, which is traditional Medicaid, the Iowa Health and Wellness Program, and the Hawkeye program. We also break that down further below to show how those programs are split across the plans. At the bottom, you will notice that this is really a point-in-time poll. So as I'm sure that you're all aware, our enrollment numbers do change because of retroactive eligibility adjustments or terminations that occur. So this was pulled as of July 19th. If we pulled it today, the numbers would probably be a little bit different. On page 4, we have today, you'll notice that the total MCO enrollment is 560,612 members, and that again was as of 7/20/2016 pulled for the April enrollment. So this is reflective of the April enrollment. For the total population, we have that split out by each one of the plans. You'll see that they all are relatively even as far as numbers. They're all within 2 percentage points of each other, so right around the mid to lower 30s. Below, you will see the percentage of members who have actively chosen that plan versus being default assigned. So if you recall some previous conversations that we had as we were transitioning to managed care, there are ways in which members are assigned to a plan. Either they can actively select in that 10 to 40 day window prior to official enrollment, or if they don't make a choice by that cutoff time, they're just default assigned to that tentatively assigned plan. So from these charts, you'll see that the majority of members are default assigned, which means that they're not actively choosing their plan, or they're happy with what they were assigned. On page 5, we have it broken out by age. From this chart, you'll notice that the majority of members are under the age of 21. Some of those members would be included in our Hawkeye program. Some are part of our traditional Medicaid CHIP program. If we go on to page 6, we have the April long-term services and supports, managed care enrollment, community-based services versus facility-based services. And as you can see, the majority of the members that are assigned to the managed care plans are receiving services in the community, which is something we definitely want to see. When we look down below, we have that split out by plan. So you'll see how each plan has the distribution of members, community versus facility. When we get to page 7, I think that this is what we're all here to really look at, are some of the performance measures and how the managed care organizations are performing relative to those key operational performance measures that we want to keep track on. So first of all, we have a couple of different measures on how they're paying claims in a timely manner. If you recall from the contract, we have certain requirements around the percentage of claims that they have to pay within key time frames. So 14 days, 21 days, 90 days. Most importantly, we want to look at the 14 days and the 21 days because we want the providers to be paid as quickly as possible. So when you look across the board for AmeriGroup, AmeriHealth, and United, out of the clean claims that they received, they're all passing that 90% benchmark for paying claims within the 14 days. When you go below that, you'll see that all of the MCOs are in fact also passing the threshold to pay 95% of clean claims within 21 days. Prior authorization is another area of concern. We want to make sure that the managed care organizations are processing those timely. We have different layers of prior authorizations. We have prior authorizations that go through the regular standard process in which MCOs have 7 days to complete those. If a provider or a member feels that there is a necessity to have that prior authorization expedited, they can request to have that considered, and the MCOs are required to process those within 3 days. We also have parameters for pharmacy prior authorizations. MCOs are expected to process those within 24 hours due to the fact that members often need their medications very quickly to treat certain conditions. So when you look at this, we do see that we have some opportunities for improvement with the managed care organizations for the prior authorization processing. We set a very high benchmark for ourselves and the managed care organizations with 100%. I will say that very infrequently did we pass and meet that threshold in fee-for-service, but we're continuing to monitor that with the managed care organizations to ensure that we're seeing improvements and that there are mitigation strategies in place to make sure that members, regardless of whether or not they meet this performance measure, are getting the services that they need. So when we look at the level in which the MCOs are completing the prior authorizations within 7 days, you see that we're falling below the benchmark of 100%. Still pretty high, but we do want to improve that. Within the 3 days, also some areas of improvement that we're working on mitigating as well. When we get down to the member helplines, what we do measure is the service level. So that's the level in which the managed care organizations are answering the phone in a timely manner. So that includes all of the calls that are received in the queue, minus the calls that we considered to be not answered timely. So calls that are abandoned or calls that are answered after 30 seconds. So for those metrics, you'll see that we require an 80% service level for their helplines. That's really an industry standard, as is the formula that we use to calculate it. All of the MCOs are very accustomed to this standard, and they're meeting those standards. In addition to that, we're also monitoring the quality of those helplines. We're using all of the feedback that's coming in from our own call centers as well as legislative inquiries, member complaints, and we're dovetailing those into the questions that we develop for our secret shopper calls. So when we think about timeliness of answering, that doesn't necessarily equate to quality. So when we measure the secret shopper responses, we're looking for not only did they answer it correctly, but did they include the soft skills that we would like to see present in call centers responding to our members and providers. So were they accommodating? Did they research the problem? Or were they curt? So when we get that feedback, we do score it. We provide that feedback to the managed care organizations, and we continue to monitor those particular questions until we see that improvement actually occur. Below all of the performance measures, you'll see the actual contract standards that are outlined in the DHS contracts with the managed care organizations. We wanted to be sure that those are included, both for your reference, but also when the public looks at those posted on our website. Access has also been a primary focus during implementation. As you recall, we have certain benchmarks in our contract for the MCOs to meet, but one of the key items that CMS focused on when we transitioned our populations over to managed care was were they going to have continuity of care? So the providers that they saw in the past, are they going to be present in the managed care environment that they are assigned to? So what we've done is continue to leverage that report. That's really the report that CMS looked at when they approved our waiver for managed care. So when you look at page 9, we have all of the key services outlined that CMS required us to monitor closely for those continuity of care standards. So when we look down the left-hand side, you'll see it broken out by adult medical providers, pediatric providers for primary care. We have certain facility types, and then we have certain waiver services that we're looking at by waiver, as well as our behavioral health services. We break that out by managed care organization, and we also break it out by region, so West, Central, and East. What we're really measuring here is whether or not, based on the past utilization and experience of the member and their relationships with providers, do they have that same access with the managed care organization that they're enrolled with? So by each service, you'll see that we're looking pretty good. There's a lot of 100s. There are definitely some areas that we want to expand, but there's also areas where there's not those providers available in the first place, and maybe the member had to travel a distance to see the providers. Are there any questions so far?
Senator Bolcom.
Thank you, Madam Chair. Thanks for the reports. A lot of interesting data. I'm interested. A couple quick questions. What is the status of paying provider claims for services provided before April 1st? Do we have a lot of outstanding bills there that providers are waiting for? Because I notice in one of the reasons claims are being rejected is because they weren't submitted for services after the 1st. So have we cleaned up pre-April 1 billings?
So to that question, we have a report that I receive daily. It's called a payables report. We are winding down payables or payment to providers. There are some providers, as you are aware, when we moved from JoEllen to the state, had changes in their billing practices that we have had to work with them on, and we have worked through those. We are winding them down. Providers have 365 days to submit all of those claims, so we have a long tail, but on a day-to-day basis, we look at those. We address those issues to ensure that they are paid timely.
How much is outstanding pre-April, do you know?
So in the behavioral health, as of this morning, when I looked at our outstanding, we had about $74,000. But again, that may go up and it may go down based upon the filings from our providers.
So that's not very much money.
No, that's in behavioral health. On fee-for-service, keep in mind, we continue fee-for-service.
Yeah.
So what was pre-April 1, purely transitioning everyone over to what is now the residual of our fee-for-service is a harder number to gauge in terms of what's left over. But in that payables report, we have somewhere in the magnitude as low as about $500,000 on a day-to-day basis, and it might peak up to about $1 million depending upon claims being filed. So we monitor that daily.
I want to make sure we clean the system out, right? I mean, if people are submitting things and there's confusion about when the service was provided and it's laying out there, it's being rejected, and because we have this new system, but the money's owed and we're just not on top of it. It's time to get anybody that provided a service before April 1st, it's time to get them paid. Okay. The other question I had is just on the denials. It appears in the first 2 months of the system, we have about a quarter of claims being denied. And your data, so you have wonderful data on the clean claims getting paid in a certain amount of time, but we recently conducted a survey of about 425 providers, and 80% of them say they've seen an increase in the rate of their denials. And as I look at this, the question I have, if a quarter of all claims are being denied, and you give us these 3 reasons: duplicative claim, service is not approved as a benefit, you should have billed the private insurance first. Is this 90% of the denials? Are these things? Do you have some data on how many duplicative claims were submitted and the value of those, right? So I'm interested in a little bit more detail on that, because I assume that some of these denials, providers are going to ask to be paid again, and are we tracking the outcome of those appeals? Because you're saying everybody's getting 100% of people are getting paid within 14 days, but we know a lot of people, actually a quarter of all the claims submitted didn't get paid. So what tracking are you doing of denials?
So a couple of things that, and I will defer to Liz on this, but a couple things that I also want you aware of is that we're also into a little bit of a culture shift with some of our providers. Keep in mind that some of our providers are used to requesting and receiving advances of claims and reimbursement. That's not how business operates in this new managed care. It is, you submit your claims and you're paid. That is an industry standard that we're moving towards. One of the things that we did pre-go live with providers, to your point, are we winding down our tail, is that we had a rapid response team in fee-for-service prior to go live. We sit down with those providers. We've had one-on-one work with those providers. We've had them bring in paper claims. A lot of our providers are still on paper claims. That delays process, and we actually help them submit them through either our systems or with the MCOs. So that's some of the issues, or some of the shift that we're seeing is a huge cultural shift to a more industry standard, and Liz can give you some statistics on this at this point.
Thank you. Well, I don't have the exact number of claims that are attributed to duplicates, but anecdotally, I'll say that there are situations in which we're seeing, when we're looking at the individual provider level of the providers that are coming forward and asking us to help with some of these billing issues, where we're seeing that they are submitting claims 2, 3, 4 times because they're not going through the first time. So they keep putting claims through the system. You know, if they submit the same claim 4 times, 3 of those claims are never going to get paid. 1 of them will. So while 25% of the claims being denied appears high, and we definitely are looking into the reasons to see if there's something that looks like it's not consistent with what we expect and consistent with our past fee-for-service experience, I want to let you know that in our fee-for-service environment, our denial rates range from 10 to 21% as well. So there is an industry standard for what percentage to expect denials. We want to get those tamped down, certainly, because we want providers to, one, have a predictable environment for when they're going to get paid. And obviously, if they're submitting a claim 4 times, which is ramping up the statistics for denials, they need more education on how to submit the claims correctly. So we're looking at all of the opportunities that we have to train providers moving forward in the fall, and I think Mikki can talk more about that. But you know, some of these instances include not including your MPI correctly, not including the correct codes, transposing numbers, making, some pretty basic things that we want to make sure that providers remember to double check before they submit the bill so that they don't keep getting denied. And then also just more nuanced things that are specific to each one of the MCOs, as well as working with the clearinghouses that we need to really dig in for training as well.
Senator Wilhelm, did you have a question? Senator Taylor.
Thank you, Madam Chair. I just want to make sure that I understand this correctly. 75% of all claims submitted are clean claims. Is that what I just heard?
The claim could be clean and it could be paid or denied, but I think that you make a very good point in that 75% of the claims are getting paid. A very high volume of the claims are getting paid, as you can see in the number of dollars that are going out the door of the MCOs.
I just want to interject here. We're talking about small providers or people who don't have infrastructure. I've been hearing from people, providers that do have infrastructure. For example, there's a large hospital in the state. They sent me some information. Accounts receivable outstanding has increased by 24%, which represents approximately $2.8 million of claims submitted, and likely net payments, delayed to Mercy, totaling approximately $700,000. Denied claims. Denials are higher after the MCO conversion by 86%, averaging approximately $1.6 million in claims per month since the transition. These denied claims represent reduced and/or delayed net payments of approximately $400,000 per month since the transition. So what are you doing? Let's not talk about the small providers. We know that we have issues with small providers. These are large providers who are experienced at filing claims, and they are not getting paid back. What are you doing with that?
I think now would be a good time, if you would, to actually ask the MCOs to come up and give their perspective and have them directly tell you what they are doing to address the claims and the claims denial, since they work with it on a day-to-day basis.
We'll get to that in a minute. I think some other senators have questions for you, however. So I just want to put that out there, that it's not the hand-holding of the small providers. There are large providers that have infrastructure, that have the ability to bill correctly, and they are still having issues. They are still having issues. Senator Reagan, did you have a question?
Well, I appreciate your reports, but how do small providers and advocates get to you guys? I mean, you've heard from me and all of these senators at the table almost on a weekly, if not daily basis, with providers who are having problems or consumers that are beneficiaries. So are the small providers getting to you as well?
There's a couple ways in which the small providers and even the large providers are getting to us. As I said before, there's two, we have launched rapid response teams. In addition to that, we actually have account managers for each one of the MCOs from the IME assigned to those providers. They can get to us through either the web page, through emails. If there is an escalation, we actually have full-time staff that actually take that escalated issue and work hand in hand with the team that will meet with that provider, will meet with the MCOs and send communication back and forth regardless of the size of that provider. And we have the same mirrored processes on the member side as well, and really are working to help those providers through this process.
I appreciate that, but I also remember a meeting we had on billing downstairs, I think it was in room 22, and each of the providers stood up and said the billing was not going to be a problem, that all the providers had been working and had been trained. I don't see that as running smoothly at this point, and you'll probably hear from more of the providers as we go forward. But when we were talking about the using a post office box for an address on a personal level as a provider, I can tell you it was my second address that I provided, and all those claims were denied or sent back. I think sometimes maybe working with the MCOs is understanding that their software could maybe be more adaptable. Providing that as a PO box as a second address seems like a somewhat of an unreasonable reason to throw out claims, but.
So a couple things. One is there's no wrong door. We want to hear from the providers. We want to work with them. We know this is a huge transition. We also know we're moving to more of an automated transition. Key to that automation is also how our providers have enrolled with the MCOs. So if they've enrolled with multiple names, one name, different service levels, because these are automated systems, that's when we are aware of issues. We actually wrap ourselves around those providers and the MCOs to try to correct those systems and or those issues to ensure timely payment for those providers.
Mikki, I think you are hearing from the providers, but they're not getting their phone calls answered. They're not getting the right answers. They're receiving, on the other end, people who are inexperienced giving questions. They're actually, in some cases, training the people on the other end of the telephone, and that's the real issue here. We're still having, since April 1st, we're still having issues when providers call to get help. And so that needs to be fixed. It needs to be fixed now, and we need to know when there will be a resolution to that. So if you can briefly react to that, and then I'd like to talk about that further and later in the day.
Again, I would say to those questions, I know we're monitoring the IME side, and I would ask that the MCO CEOs be able to speak to those points that you just addressed.
Senator Johnson.
Thank you, Madam Chair. This has to do, and it may be for the MCOs, but this has to do with access, in my opinion, but for some members, you have to get to your provider. I just met with our Regional Transit Authority Executive Director yesterday, and most of the claims that were submitted before April 1st are still not paid. And I just wonder if we're going to address that today. These regional transit systems are under a lot of financial pressure already, and this doesn't help the situation. So you have to get to your doctor. So that's just my question. If it's not appropriate right now or can be answered later, that'd be great. Thank you, Madam Chair.
Senator Garrett.
Thank you, Madam Chairman, and thank you for your presentation so far. I've got a couple of what I think are probably fairly simple questions, but when a claim is rejected or denied, is the person that submitted the claim, are they told why it was denied? Are they supposed to be told why it was denied?
Good question. Yes, absolutely. All providers have access to reports that tell them whether or not their claim was paid, whether or not it was denied, and for how much. The same is true when they submit claims to a clearinghouse. They have access to reports that tell them whether or not their claim was rejected at the front end and the reason for that as well.
And then I have another, I'm sure it's a simple question, but it just occurs to me. We've got 500 and some thousand members in the system. If you have a family, say a parent and 2 children, is that 1 member or is that 3 members?
Another good question. So they are 3 distinct members. However, depending on the circumstances of that family unit, most likely we try to put them on the same case number so that we can keep that family together for MCO assignment.
But in terms of your statistic of 500 and some thousand members, in that circumstance, that would be 3 members, right?
All distinct members.
Yes.
Correct.
Liz, IME kept statistics on claims paid and claims submitted and claims denied in the past, correct? Okay. So out of claims denied, suspended, and rejected, you have 1652704. That's what that totals in that group. And then claims paid, 3.4. How does that compare to last year's numbers or the year before where, just to get a global view. So how does that compare to the system that we used before?
So, good question. So if we looked at the level of claims that were denied, let's just say June of last year. I have that 1 second. So in June of last year, the IME denied about 13% of the claims that came in. And then of total claims. That doesn't include, of course, the claims that were rejected at our clearinghouse.
So this is quite a bit of an increase.
It is, but like I said, during the whole year, it ranged from 10% to 21%. So depending on what point in time we're looking at, it could be a 15% increase or a 4% increase. I think we don't underestimate the need to keep an eye on it and to try to get it to go down. I'd like to get it to go down to about 10%.
Senator Bolcom?
Thanks. Continued on with the kind of the denial of claims issue, yeah, I can appreciate that providers in this new system are having some snafus, in submitting things, and we've dramatically increased the administrative responsibility. There's providers, they just billed state before Medicaid, now they've got 3 different entities to bill, and actually the survey we just did said 90% of providers have increased administrative costs to manage this new system. And so I get we have a new culture, but it was suggested, Liz, that there's an industry standard on denials, and I'm sure there is, and it concerns some of us that the way these companies are going to make money on Iowa and our people is that we're going to continue to see these these kind of denials at a rate that would exceed anybody's expectation about what would be a good system. So I'm just wondering, this is obviously going to be an issue that we're going to see again with the next reports in the next few months, but there's a great deal of concern about people getting the services they need, and we all have heard the stories from our providers and our consumers on this, that they're just not getting what they need, and it appears to show up to some degree in these denials. I mean, the survey also said that nearly 30% of providers had to take out loans from the local bank in order to make their payroll, and 66% reimbursed at lower rates. There's some signs here that there's troubled water out there, and I hope that as we go forward and I get the sense that you're paying attention to this, but more detail around these denials is going to be really important as we go forward.
Senator Yoakum.
Chair, thank you for being here, both of you. So I wanted to go back to an email that we got from Paige last night at 6:20 last night, and it kind of goes back through some of the data you already relayed to us this morning, including an average process time of 8.5 days. Okay, so what's the median? What's the mode? Where half are paid on time or within an acceptable number of days, and half are not. And then what is, of course, the mode, the most common? I'd like to have that information. This list claims suspended. I'm assuming you mean delay. And I want to go back to what both Senator Bolcom and Mathis have said. Services that have been delayed or denied, it says service is not an approved benefit under the Medicaid program, which is a reason for a claim that's been denied or rejected. So what services are no longer being paid that were under the other system? And I say that because we're getting so many emails from providers who provide speech therapy, occupational therapy, and physical therapy who have been trying for months to get paid and have not been paid, and have tried to work with the MCOs and work through whatever the issues are, and they're getting nowhere, and we have to intervene on all of these issues. So I'd like to know what services we were paying for before that we are not, that our providers are now having a really hard time getting paid for. Is speech therapy, OT, PT no longer a covered service?
That's a really good question, Senator Yoakum, and let me explain and clarify what that statement actually means. The services not covered under that program means that some of our Medicaid programs have a limited benefit package. For example, our Iowa Health and Wellness Plan doesn't have access to all of the behavioral health services that standard Medicaid does. They don't have access to the rehabilitation program. They don't have access to our 1915B services, so our residential substance use treatment services. So that statement really is a reflection of a service being billed for a member that actually has a limited benefit package. It does not translate to mean that we're not covering services under managed care that we had previously in fee-for-service.
Okay, so the individual, it's not just one, it was several that have been emailing, I think many of us sitting at this table, and in the past, they were paid for these services. They are now fighting tooth and nail to get paid for these services. So what's going on?
Again, the benefits are the same. Medicaid's paying this, it's the same benefits we had in Medicaid, same benefits in Iowa Health and Wellness. We can work with those providers if they bring attention to us. We walk them through that, which some of them have, and we've actually, I know that speech therapy has been an issue that we have been walking through even before managed care to ensure payment. We have regular calls with those individuals to walk through that. Our strategy is no wrong door. Let us know what it is. We'll walk you through it. We'll help you understand the benefits and which plan the member may be under in terms of a Medicaid benefit plan, and move forward as best as we can to ensure timely payment so the members can receive their care.
Office put out yesterday, and I'm assuming they get the information from you. Okay, so they are saying that access to providers, and they're saying that under the previous Medicaid system, the number of doctors and osteopaths that had contracts was 7,512. Now, there's 11,224 licensed docs and osteopaths in the state of Iowa. Then we go to the current privatization system, and it says that there are 119,564 provider contracts. Well, obviously, it's more than we even have licensed. But I actually understand, or I'm sorry, 16,821. I understand what you're getting at, because under the previous system, there was only one manager of the system. That was IME. Now we have 3 managers, okay? So if you're using averages, because you average 8.5 days for payment, if I just took an average then and said, okay, well, I get it. Under the previous system, we're counting contracts. Now we're counting contracts with 3 managers. So if I divide it out by 3, because we have 3 managers now, it would mean we now have 5,670 docs and osteopaths with contracts in the state. If I take away the duplications, because the same doc most likely has a contract with each MCO, and we're counting each one of those. If I look at advanced nurse practitioners, in the past we had 2,526. Now we're saying under this system we have 5,670 contracts. Divide that by 3, we're at 1,556. So if I'm just dividing this out by the number of people who are now managing the system, we actually have fewer providers contracted. So to just clarify this for me, I don't want to know all the names of all the providers. I just want to know how many docs are contracted with AmeriHealth, how many docs are contracted with each of the MCOs, and then I'll do the comparison. So I'm doing apples to apples, because previously there was only one manager of the system, and that was IME that they contracted with. Okay? So just get me that information.
Sure.
I have to respond. Just want to know. Because
Well,
the numbers
can-
aren't jiving in my head.
Right. So I can tell you that 98% have contracted with one of the MCOs, 82% with 2, and 73% of all of our providers have contracted with 3 of those
Right.
providers.
I'm just saying the way this is listed can be somewhat misleading. That's all I'm saying, the way Governor presented it. He has the right to do it. I'm not saying that it was necessarily inaccurate, but certainly misleading, because we are now comparing apples to oranges, not apples to apples. Okay? That's it. Thank you, Madam Chair.
which providers are getting rejected? So is there, can you see, Liz, a concentration of, is it CDAC? Is it, which area are you concentrating on that needs the most help in rejected claims, or are you? Just kind of flesh that out for us.
Great question. Senator Mathis, we are working with the MCOs to bucket how those claims are rejected, and we're not seeing that one provider group overwhelmingly is receiving a higher percentage of rejections. It's relatively spread across. So we're trying to figure out key ways in which we have some general training across all provider groups that can really help in getting those claims through.
And then in pre-authorization, so pre-auth is one of the things that we hear from the providers as well, especially in mental health, when pre-authorization needs to be made quickly. You have a person who's in crisis. And so what kind of statistics are you keeping on the time that it takes to get pre-authorization approval?
As you recall from the performance indicators that we have in the monthly reports, we do have contractual timeframes for getting those prior authorizations completed and the decisions rendered out to the providers and the members. So we have the 7 days for just regular prior authorizations, and then the 3 days if the provider or the member requests a prior authorization be expedited for whatever medical reason that they might need. So we're evaluating that really closely to see if they're meeting those timeframes, as well as ensuring that there are protections and safeguards in place regardless of the timing of that prior authorization, so that the member actually does always receive the services that they need.
And then you said that you want to get down to 10%, where we're talking about claims, right? You want to get down to about 10%. So tell me, give me a work plan. How are you going to do that? When will that happen? So how will you do that, and when will that happen?
So a couple things, if you will. On prior authorizations, if you also remember when we went into the transition, we had 90 days with prior authorizations. If they had the existing ones, we would continue to honor those as a learning for us and our managed care plans. Prior authorizations, a lot of our our providers worked with the MCOs on prior authorizations in education and learning. In addition to that, if there is an emergent situation, the person is going to receive their care. Regardless of a prior authorization or not, the person will get the care that they need. And that, again, the MCOs can reiterate that for you, that we're going to make sure that if they need the care they need in an emergent situation, they can get that. In terms of claims, we have put in place work groups already. Things that we are looking at are systematic issues, similar to there's a whole litany, and it's a very complex process of edits and where those edits are applied in billing. Are there specific trends we're seeing that are causing the denials, such as members enrolled with an MCO for one type of service but actually offer multiple services? They can only be paid for what they're enrolled in with that MCO. So do we have to go back and educate in ensuring enrollment in all of their service lines with the plans? Understanding what those denial reasons are. There's an internal work group at IME looking at those, led by Liz Matney, and then there is a work group across IME and the MCOs looking at more of if it crosses between the IME and the MCOs. Our goal is to have a lot of that analysis done within the next week to 2 weeks, and then to put in place whatever strategies we need to be putting place forward. And then we have sat down with the MCOs, and it should be coming out shortly, a whole series of trainings that will also be webinars going across the state between now and mid-September on some of the key things that we're finding, like don't forget your NPI. What are some of the things on the claims forms? Because if you remember, the providers are using the claims forms we used pre-MCO. So the forms haven't changed. It's what are those things we need to button up a little bit with our providers to get them tight on those forms, understanding coding, and how that all works. Also, in the middle of all of this transition, don't forget, we also moved to ICD-10 last fall, and so there's a whole litany of new codes. So what are all of those? So we have a very comprehensive strategy and work plan that we're working on to try and get our hands around this, to try and move those denials down and to work with both the providers and the MCOs in a collaborative way to address it.
In any kind of data work, if it's garbage in, it's garbage out, right? So do you feel that you handed off to the MCOs clean data, or how good was the data that you handed off on both your providers and your consumers?
The data we believe we handed off the data to assist them with where IME was with our providers and our billing practices. Do I believe we have a cultural shift occurring? Yes. IME definitely was less automated, was more, bring your claims in, we'll work with you, and help. We are moving more towards a standardization to gain efficiencies as well as to gain automation with those providers. So the data is clean, and we've verified that several times with our MCOs in terms of the data we've provided them to make sure that they had the provider's right NPI number, the information that they needed, as well as what our members were enrolled with. But we do believe we have definitely a shift in less automation from the IME and more automation on the side of the MCOs, and working with them in this new system of paying up front and working with our providers to have them paid up front. In the past, IME would pay 100% of claims and then go backwards and work on claims to clean them up. We're now where we're actually denying on the front end and not going on the back end and cleaning up some of those claims. And that's our shift.
Any last questions? Senator Bolko.
The comment, we've talked about the providers a lot, right? And we've kind of taken away the notion, these are employers. In many communities, some of our bigger employers are important employers, and we've kind of moved. When we refer to them now, we refer to them as providers, and we've put them under incredible stress. The people that run these organizations. I think of the notion of regulation and red tape and all the chest pounding around this place around when we do things and pass laws that impact small businesses, right? And we know that, and I don't know that we're tracking this, but according to our survey, 90% of providers have to spend more money to administer this new wonderful thing we've handed them, right? And then they're in this new culture that we're laying on them, that you got to do it this way now, times 3, and we need to have a little bit more accommodating attitude towards our providers as this thing rolls out over the next 2 months or over the next months. We've been in it 2 months. They've had to go to the bank and take out a loan. Additional costs. It doesn't provide a service to anybody other than making sure they can keep their people on staff and make payroll. So I hope as to the MCOs and to IME, if we don't have quality providers, we will not have a system. And I think there's some providers out there that are pretty doggone vulnerable to this new culture. And what we've done to them as state government, what we've done to these small businesses by way of new red tape and regulation and headache, that as we go forward, we do our best to make sure people do get paid on time, and and work to make sure these claims get done right, and the training that's needed. Seems like we still have work to do in that regard, but I just want to put a little emphasis on who the heck we are talking about here, Madam Chair.
Senator Bolko, I totally agree with you, and that is why we're here to help. I mean, this is a transition, and it is one of the largest transitions with 500 million people who have providers who care for them in a compassionate way. I came from the provider environment. I know what kind of a transition this is, and we're here to help. I have literally seen staff come in, sit down with them. We have several providers with paper claims all the way up to big system providers. We meet monthly with our association executives. Tell us what you're hearing about your providers who are serving our members. How can we help you, association executives? What do we need to do to help? I meet with the largest health systems almost every other week. I meet with the FQHCs. To your point, sir, we are taking this seriously with all the compassion that we can to make sure that we can move this transition effectively and smoothly to really work in collaboration with them. We've put rapid response teams in place. The MCOs can speak to the strategies that they have in place. I can tell you, a day doesn't go by in an evening that I am not thinking about what we can do to outreach and to be supportive and to help providers. Was a provider, I understand it. I understand the people they serve and the people we serve, and want to make sure that this transition goes as smoothly as we can make it with as much support as we can provide those providers to ensure that the system is sustainable, it is efficient, and that we can continue to serve patients for years to come.
Okay, thank you, Mikki. We have one more question just in from the Newton Kiwanis, Senator JoEllen.
I apologize for being late, but I had a prior commitment with the Kiwanis. I didn't want to let my constituents down for that. Hey, I just want to give a perspective on what we're going through today. So right now I'm texting a mom who's got her mother in a nursing home, trying to get her into I think she's actually going into hospice, and she's owed money. She's filled out the paperwork. I'm texting her right now. I think she wants me to jump on this table and start throwing things, how she feels. I think, and put more perspective on it, I walk in here, turn on my email, 10:06, I got an email about a mom trying to get, and there's exclamation points in here, so they're not being as polite as we are. Eye care clinic, 10:06, 10:31, the other email. We spent 2 years trying to get a small town clinic into a small town in northern part of Jasper County. We got that. They are now not going to shut their doors because their receivables got too big. They were a startup kind of deal, and then when this happened, their receivables got too big. I had a constituent arrested because he was off his meds, and we got that resolved, but we had to go through the court system to get that squared away. I have one of my major clinics is owed $200,000, and it's one of my big providers. I mean, they're trying to get that done. My eye care clinic is getting pre-authorized, then denied service, and this is just in a day's kind of work of what we're doing. So, I mean, I don't even know these two emails I've got to resolve them. So it's not really a question or anything. It's just a statement of what we're going through. And the emails with exclamation points, they're frustrated. I mean, these are people that are absolutely frustrated. And I think if I presented how they're presenting to me right now, it would not be very senatorial. So just a perspective. So thank you, guys.
A lot of frustration. Final question, Senator Johnson. We're at 11:02, so providers are up next. So go ahead.
Okay, thank you very much, Madam Chair. I want to underline Senator Bolcom's comments too. I learned yesterday in talking with long-term care providers that they are borrowing money, because of this lack of or this delay in payment for whatever reason. Not only that, but they're having to hire additional staff to get these claims in. And it's no joke in rural Iowa that long-term care facilities are some of our largest employers in their communities, and they're essential to us. It's not a sexy job doing that, and they're having a hard time finding enough qualified nurse employees to staff that. I just want to underline that they're borrowing money. It's kind of a reminder of the 80s when school districts couldn't get their payments on time. We had to force them into borrowing money. We shouldn't be forcing these people into borrowing money. So I just want to underline that. Thank you. Thank you, Madam Chair.
Senator Johnson. Thank you for coming, Liz and Mikki. This is a lot of data to process. Thank you for bringing the numbers to us, although I know you were working up to the last minute last night, but thank you for providing them for us today. They served as really a starting point for us, right? This is a benchmark. And hopefully we're going to have better data the next time we meet. We will have an oversight committee meeting in August, so hopefully that's, we'll see some progress even within a month or two. So thank you for coming and doing this, and we'll hear from you again this afternoon. So now up next we have 3 providers. four providers who are going to, if they could take seats up here. Sara Allen from the Iowa Hospital Association and the Director of Government Relations, and she's a staff attorney. Tim Roberts from ABCM Corp., who's the Chief Financial Officer. JoEllen Arends, she's an RN, case manager for the elderly waiver at Franklin County Home Care Service. And Kent Jackson, the Director of St. Luke's Behavioral Health. All right, and before you make your statements, if you have statements, please identify yourself and then make your statement. Thank you. Sara, do you want to start?
All right, Sara Allen with the Iowa Hospital Association. Thanks for letting us come speak today. I'm just going to share a little bit with you about what the association is doing and then kind of give you a 10,000 feet view about what we're hearing from our hospital members throughout the state. Wanted to kick things off with the introduction of a process that we just got kicked off last month with the MCO companies and then also DHS. We're calling it the TAG process. It's a model that the Kansas Hospital Association followed when they implemented managed care, and it stands for the Technical Advisory Group. So it's a group of hospital members that comes together with all of the key players in the system to kind of go through technical issues that they're experiencing. So a lot of issues that have already been brought up today, prior authorizations, billing issues, those are all being talked about. So we're excited about that endeavor and really have had good working relationships so far with the MCOs and then obviously the DHS staff who are very responsive. I also want to point out before I get into some of my comments, we don't have any definitive data. So I'm not going to have data today that says all 118 hospitals throughout Iowa are experiencing X, Y, or Z. Most of what I'm going to share with you is anecdotal, but I do think moving forward we'll be able to see some more definitive trends and be able to compare month to month, which will be helpful for all of us. The three tiers of problems we are hearing from our membership really the first hinges on prior authorizations. So I think you've heard a little bit about that from Director Stier's comments today. Biggest thing we're hearing is it's taking a lot of staff resources away from actual patient care. Worst case scenario I've heard about is a physician that was on the phone for multiple hours with the MCO trying to get an authorization on whatever service they were talking about. This is obviously not something we would want to see repeated in any situation. As you know, workforce shortages throughout Iowa is a big deal. We're talking about a vulnerable population too, so definitely want to move away from that. Back to my TAG work group, though, we did talk to all of the MCOs and DHS last month about the prior authorization process. And you'll see on the DHS website, there's actually a crosswalk matrix that talks about each MCO's prior authorizations based on the service that you're trying to get authorized. Definitely think this is an ongoing tool that needs to be updated. DHS has made a commitment to continue to update that at least into the next foreseeable future, which is a huge resource for providers. One of the biggest things that really providers were hearing, hey, keep this thing going. So excited about that. I do want to go to Senator Bolcom's comments earlier, though. It is a huge burden on hospital staff. I've probably been in 10 different hospitals in the last month, and this is the biggest thing I'm hearing is my staff resources are just dwindling. Some staff or hospitals are actually adding employees to deal with these increased administrative issues, and then some are just having to kind of pass them along. So their staff's getting stretched thin. They don't know how long they're going to be able to maintain it, so on and so forth. And then one last thing with the prior authorization piece is just there have been reported inconsistent responses from the MCOs, which maybe that's just as we're rolling this out in the first 3 or 4 months, but we would like to see some more consistency. That's also something our TAG work group is trying to work with the MCOs on, is creating consistent policies for providers' ease of using their systems. Second tier of issues are claims payment issues. At the start of implementation on April 1st, for prospective payment system hospitals, so that's 28 hospitals in our state are paid on a prospective system. Outpatient rates were actually incorrect. So we are now dealing with like a 3 to 4 month period where those rates are going to have to be recalculated. Again, at our TAG meeting, we brought this issue up with the MCOs. I think now, maybe into the next couple weeks, we should be getting the correct rates, but this is a big deal when you're trying to look kind of globally about how am I doing, what's getting paid, what's not getting paid. You want to have the right rates. One other issue that I'll bring to your attention is the rural health clinics payment issues. Most critical access hospitals are affiliated with a rural health clinic. The payment methodology has kind of, from my understanding, has changed just prior to the implementation of managed care. So there's a lot of questions surrounding this, but I do commend the department. They have had a lot of informational letters on this topic, but a big deal for critical access hospitals who are affiliated with that program. And then I think we've talked about claims being rejected today. We're hearing that from our membership, that certain claims are just being rejected, and it's taking time to figure out why is that claim being rejected, and then at the end of the day, okay, is it just rejected because of policy or what? One thing we did just hear about from a hospital just north of here is denials for court-ordered inpatient admissions are being rejected. I don't know if this is per all 3 MCOs or not, but obviously this is an example of the things that are a big deal to hospitals, and the component of behavioral health, I thought.
Sara, repeat that again, will you, so everybody hears that?
Yeah, it's denying court-ordered inpatient admissions at hospitals.
Did you all hear that? You all understand what that's about?
This we just heard about on Friday. They had tried to do something with it 3 times, so I don't know the final resolution on that or not, but obviously, if you're being court-ordered to a hospital, that hospital's bound to take care of the patient. So that was kind of a red flag, like, wow, what's going on here? So hopefully it is some sort of issue that can be taken care of. But just an example of what providers are experiencing right now. The third tier of issues I wanted to talk about are delays in claims getting paid. Again, we don't have definitive data where I can say, 20% accounts receivable is up, but if you talk to individual hospitals, they do have those numbers. So I would encourage all of you, if you are talking to your local hospital CEO, ask them, hey, how are things going? And they should be able to give you kind of their snapshot in time. We have heard that denials for claims paid are around 15%. I think that's kind of a good number, 10 to 15% of what we're hearing that from members that are reporting on that. But again, this is a big issue. And then just one thing, again, something we just heard about last week, but some of the downstream issues you might not think about. We had a hospital report to us that some nursing homes who aren't getting paid are now saying, hey, we don't want to take the Medicaid patients because we're not getting paid. So, some of these payment issues really do create bigger barriers. But, we are very happy to work with the department and the MCOs to resolve a lot of these issues, and, hope we can continue doing that to benefit our membership. So thank you for your time today, and if you have any questions, I will be here.
Can I just take a quick show of hands? How many who are attending here are providers, or you're with a group, you represent providers? Raise your hands, please. Okay. And how many of you, aligned with what Sara is saying, how many of you are having the same issues that Sara's talking about? Okay. And then how many of you have been denied claims and you're owed money right now? Show of hands. Okay, thank you. All right, so we're on the same wavelength here. Just demonstrates who's here and why they're here. So, thank you, Sara, and we'll reserve the questions to the end, so stick around here. And then I have JoEllen Arends, who is the case manager for the elderly waiver at Franklin County Home Care Service.
That is correct. And I bring a much smaller perspective, and I bring 2 perspectives. One is my own experience as a case manager, and I've done this for 5 years. The other perspective is of those providers that I work with to try and maintain our elderly safely in their homes. From my perspective, there is a total educational gap here in that when the MCOs took over, there was a lack of understanding of how our waivers functioned and what was necessary to make them function. I actually had MCOs off the record say, we never got education, we don't know what this is about, we've not done this in other states with waivers. They did not know what the notice of decision was, nor how it functioned, why I would want it, why the providers felt they would need it. Timeliness is an issue. When we began the transition April 1st, MCOs were quite transparent in saying, you know, with all this transition, we're about a month behind in approvals. As of Monday, yesterday, they told me they were 2 weeks behind in approvals for long-term care. This is complicated by the fact that in the prior system, services were approved for 1 year. Now we must approve services every 90 days with the MCO. And when they're already behind, you can see where providers who are already not getting paid are hesitant to provide the next month's services if they have no proof of approval. I was told if there were immediate needs to contact care connectors. I leave voicemails, I send emails, I get no responses until I start working up the administrative chains with the MCOs. And my people who have needs are left to wait until I can get a response. Notification of services closing. Prior to this, when someone either didn't meet financial eligibility or level of care eligibility for a waiver, it came through the ISIS system, and the case manager could facilitate what needed to be happening, whether it was discharge or whether it was counseling the member on what they needed to do to maintain their services needed. I've had members, I found out just last Thursday that a member of mine was financially declared ineligible effective June 30th. No one notified me as a case manager. No one notified any of the providers. We have providers who have now provided all of July, or all of June into July, and they will not get reimbursed for these services because she was declared financially ineligible June 1st. But no one was told. The ISIS system is now closed for those members. DHS does not notify us. I actually said to an income maintenance worker, I feel as though I'm going in a circle. And she said, you are, we are. We don't have any answers to this. From the provider's perspective, I was told the middle of June that there were several providers who were going to quit providing services July 1st because their accounts receivable were far too high. One small community facility that is not associated with any large corporation, they have no financial backing that can help them absorb these costs, is $58,000 behind. They were told to have a 3-month supply built up for payroll and things like that. And when you have a very small facility, a 3-month total expenditure cushion is a little unreasonable. The providers are telling me that approvals from AmeriGroup, United Healthcare only contain limited information, and so starting services for someone when you don't have a phone number, an address, they spend multiple administrative hours trying to get this information so that they can provide services. They are also not notified when a new person is approved for a service. They have no way of knowing when someone is approved. Franklin County Public Health tells me that they are spending an overwhelming time in communicating to provide services with the MCOs. They're getting different answers from different people within the same MCO. AmeriHealth, Caritas, and AmeriGroup both told Franklin County Public Health to put PRN visits in their prior approvals. And then those PRN visits were denied, and they were told they need to call at the time those PRN visits are needed. As we know, in home care, patients' medications change frequently, and to go in and monitor and reset their meds when their medications change puts an undue burden on these providers to sit on the phone. It may be 3 or 4 times a week that their medications change. AmeriHealth Caritas has lowered the number of visits for the nursing agency and then request a peer-to-peer review, they call it, to increase that number of visits. That requires physician to a physician. And that requires physicians to call in on a schedule to do this physician-to-physician peer review. Again, an unrealistic expectation, especially in our smaller rural communities where we are pressed to have doctors in the first place. Reimbursement issues, our small community providers tell me that one said 58,000 behind. One said that regardless of how many meals are approved, and according to the elderly waiver, they can have 2 meals a day provided. That's 62 meals a month. AmeriGroup is paying 14 meals, period. They are out that reimbursement. They have no explanation why. They have no explanation as to if that is going to be caught up. Their inquiries get no answers. They're very frustrated by that. Another provider told me that they're over $100,000 behind since April 1st. Many attempts at communication, and they have no indication why. School bus sales in Waterloo, Cedar Valley Mobility, tells me they are $50,000 behind. I've had 2 providers tell me they're getting no reimbursement for liquid supplements at all. And I have people who cannot maintain their weight without them. They are at jeopardy of entering a nursing home. We know that more home care visits decreases complications, hospital emergency room visits, entry into nursing home, but yet all those things are being denied and lowered. But the saddest thing that I have heard, the most unconscionable thing, I just need to recap for you what happened to one of the members I serve. She fell on June 26th and fractured her foot. She was put in a temporary cast, non-weight bearing, already had balance problems before this, and mind you, to be on the waiver, she's already met nursing home level of care. She was sent home. And they said she probably should go to a rehab center, but you can deal with that in the morning. So we're sending a compromised patient, fractured foot, home. Her family took off work and stayed with her and began that pursuit in the morning. 2 family members it required because of her loss of balance, of not having weight bearing. She already had poor balance. They were told they could not pay the nursing facility privately because she was on Title 19. The family paid privately at a hospital at a rate of $250 a day for her to get care for a week. That's what they could afford. And at the end of that, or in the middle of that week, on June 28th, they put on an air cast, which really sent her balance over the edge. On June 30th, they were told by the nursing facility staff that the MCO had denied their request for nursing facility care. That is the part that boggles my mind. She already met nursing facility level of care before she fractured her foot. Her choice was to receive it in her home. That's what the waivers are about. On June 3rd, she then returned home. July 3rd, she returned home. On July 4th, she fell and fractured her pelvis. She's now in the nursing facility. This did not need to happen. She and her family are both paying the cost of this.
Great, thank you, JoEllen. Stay right here, or you might want to switch seats maybe. How about now Tim Roberts and Kent Jackson? Could you come up? Thank you for your testimony. And if you two are comfortable sharing a microphone, and we'll have Kent stay there as well. So, Tim, would you like to begin? And we have, just to keep time, so it's 11:24, and we're scheduled for a break at about 11:45. So we have about 20 minutes or so.
Thank you for allowing us to present here today. No. Thank you for allowing us to present here today. A little background on ABCM Corporation. We own and operate 30 nursing care facilities in Iowa. We employ approximately 3,000 people with a monthly payroll of in excess of $6.5 million. As of yesterday, we're still owed over $3.3 million for April, May, and June services. In order to make up this delay in payments, we've had to increase our short-term borrowings by $3.3 million to make sure we made payroll and make sure we've paid our vendors. Among the 1,540 elderly Iowans that we cared for in our nursing facilities last month are over 900 Medicaid recipients. This represents about 59% of our total number of residents in our facilities. As of yesterday, we had received only about 31% of the total billings that we had billed Medicaid program for the month of June. If we were still being reimbursed for these services directly by the state of Iowa, we would have received nearly 100% of these payments. In July's situation, it would have been by the 7th of July, because we would have been allowed to submit claims the first Friday of the month, and just like clockwork, we would have had the money by the following Thursday. As providers, we have always appreciated the way Iowa has maintained Medicaid funding levels, while so many other states have found it necessary to cut Medicaid funding. We've always been able to count on Iowa's funding of the Medicaid on a specific timetable, counting on that money to provide services or the payroll to our employees and pay our vendors. It is our understanding that according to the state's contract with the MCOs, the allowable payment timetable was pushed from 1 week to 2 weeks. This time frame has actually become more like 30 to 60 days, and in some cases more. Because of this $3.3 million shortfall in payments, we have had to lay off a few people, to date less than 20, but that could grow if this shortfall continues. Another process or another circumstance that this delayed payment is going to cause is this week, our nursing facility quality assurance assessment fee, commonly called provider tax, is due for the April, May, and June. So we're going to be forced to pay approximately $867,000 in provider tax to the state when we are still owed over $3.3 million from the MCOs. The shift to managed care organizations has placed a huge burden on ABCM and other providers to the Medicaid program by not timely providing the cash flow that they desperately need to remain in operations.
Ask you something briefly,
Sure.
Tim. Why is the reason you're $3.3 million owed? Tell me, if you could, for what reason ultimately is it, are they denying your claims, and for what reason?
They are denying claims, and in some cases, we don't know what the reason is until we start researching each individual claim. In one case, I think this was in May, we had one MCO just deny every claim for about half of our facilities with no explanation. Then we just have to go back and work those claims with that provider or with that MCO.
So you don't know if it was incorrect address or
Not-
coding or?
Not initially, only after we make the contact back to them, and then it's not apparent from the electronic information that we can get.
Okay, stay right there. And Kent Jackson, Director of St. Luke's Behavioral Health. Welcome, Ken.
Well, thank you for letting us come and share some thoughts with you today. I've been at St. Luke's Hospital for approximately 29 years, and about 20 of those we were under Magellan Medicaid managed care. In behavioral health, Almost 100% of the care we provide is under managed care from a variety of companies. So we've become accustomed to dealing with managed care since the mid-90s. Generally speaking, I have about, just in behavioral health, with about 200 employees, about 5 full-time equivalent staff spent their time dealing with Magellan, and that number has recently grown by probably about 1.5 FTEs, full-time equivalent staff, just in behavioral health. Across the hospital, it's estimated right now that it's been about 4.5 full-time equivalent staff in addition to what we already had. So it's been a huge financial burden, and for the most part, we have not hired additional staff to do that. So what it means in a lot of cases is you're taking clinicians away from dealing with patients and basically on the phone or filling out forms. The new managed care companies are all about paper, unlike Magellan, who did most things telephonically. So they have reams and reams and reams of paper that you have to fill out. And on the intensive outpatient services where people come pretty much 5 days a week, up to 6 hours a day, and on inpatient, you pretty much are reviewing every patient every day. I got 72 beds, so for full, that's like 72 reviews a day just for inpatient, not including approximately a dozen outpatient programs. One concern I've shared before at some of these public hearings and listening posts is just the speed with which these companies operate is in no way conducive to providing limited resource such as inpatient psychiatric care, which is a huge shortage across the country, and there's a huge shortage in Iowa, and we have an even bigger shortage with regard to providers, psychiatrists, and licensed nurse practitioners. So if we have to wait with an average length of stay of 6-7 days, we have to wait 4 days to get a decision about something. You can imagine the cost of that in terms of wasted service. I think after 20-some years, or approximately 20 years of dealing with managed care, my biggest concern about all of these companies, including the ones that are managing Medicaid in Iowa, is that they make decisions without ever knowing the patients, without ever seeing the patients, and they are not at all hesitant to tell the people that are treating them, that do know them, that are seeing them every day, what to do. It's a really flawed concept, in my opinion, and I've always felt that way, and I've shared it actually here before. So I want to give you a few specific examples of things that we're having problems with. One would be medications. The one thing that psychiatrists and psychiatric nurse practitioners do that is their strong suit is prescribe medications. But in fact, with these new managed care companies, we're having tremendous difficulty getting the medications that they want to use approved. We've had patients come in that are already on a medication, but the rules are that they have to fail on 2 cheaper medications before you can prescribe the one they're on, so then they're saying, no, we're not going to approve that. We've had waits as long as 4 days to get a medication approved with, again, an average length of stay of 6 to 7 days. I have, in my psychiatric outpatient clinic, which provides psychiatric services from doctors and nurse practitioners, they estimated that they're probably doing 3 times the prior authorizations that they were before April 1st. I think in general we try to be very cognizant of the fact that a lot of our patients are poor, and the medications that they have, especially if they're not Medicaid, we try to match up medications that A, work, but also that they could afford to pay for, because a lot of the newer, most effective antipsychotic medications particularly can cost over $1,000 a month. And again, these companies are not wanting to spend that kind of money, even though those are the medications that oftentimes will do the job that needs to be done. We're not getting paid for, other than one of the companies pays some on court-ordered substance abuse committals, and JoEllen mentioned that earlier. It's my understanding that the companies were directed to pay for all court-ordered days on mental health, and that's an improvement over Magellan. They did not do that. But on substance abuse committals, business we would like to not be in because we don't treat substance abuse. We tie up psychiatric beds, sometimes for weeks, waiting for placements for people to get treatment. Many of those stays are not paid for at all. So we provide weeks of care at a very expensive rate per day, tie up a psychiatric bed, which is in a shortage situation, and we get no reimbursement whatsoever. We've waited up to 4 days, or 3 days rather, to get approval, even with court orders, to move those patients to a substance abuse treatment facility. We have had to wait up to 3 days just to get approval from the companies to send them there, even though they have a judge's court order to go there, and I'm not getting paid to take care of them. It can take, with one of these companies, AmeriGroup, it can take 3 days just to find out if your services are authorized. We take pride at St. Luke's in providing services to psychiatric patients regardless of whether we're getting reimbursed or not. And I would want to really underscore that. We do not, like many hospitals, we do not discharge homeless patients, and there are many psychiatric patients that are homeless. We do not, what the term that is commonly used, we do not discharge them to the street. We keep them till we find a place for them. And again, if you're not getting paid, that's a very expensive venture. We keep track of what that costs us in behavioral health per year. And the last year that Magellan was around, it exceeded, just in our behavioral health services for inpatient alone, the write-off was over $1 million based on what they would have paid us for days of care we provided. If we base that on charges, it would be double that. But I'm talking about what they would have paid us if they paid us at all. And I don't have any numbers yet, but we're starting to accumulate data right now on what that looks like for the current managed care situation that we are in. The last thing I would say is, again, I mentioned it earlier, the amount of additional labor that it is taking to deal with these companies is shocking. And as I said, I think across our hospital, we estimate about 4.5 full-time equivalent staff in addition to what we were spending in the past, which was already a fairly significant amount of money. So I will stop there. And again, I want to thank you for letting us come today and share our concerns with you.
Thank you all for testifying. This really paints a picture of a disconnect between what the numbers show and what is actually happening in our districts, what's happening across the state. It's great to have the numbers and show some percentages, but when we leave people behind, that's not good. We're leaving people behind. So questions here for Senator Reagan.
Thank you all for being here. You talked about the substance abuse, the court-ordered substance abuse. Are all 3 companies not paying on that, or are there particular?
Under United, Optum is their behavioral health carve-out company. They sometimes pay, some days are totally unpaid by all of them. The other 2 don't pay anything, as far as I know. And Sara made this point earlier, and you have a judge's order.
Was that paid for before?
Magellan would pay 1 day, which
Okay.
again was totally inadequate, but 1 day is better than no days.
Okay.
They would pay 1 day, typically, that's all they were required to pay. If somebody was in detox, we do some detox on our psychiatric units, like alcohol, benzodiazepines. The withdrawal of those drugs and alcohol can be fatal, so it's medically a very serious situation. But by the end of the Magellan contract, they were not paying for detox patients unless they were showing active symptoms of withdrawal. And so we, again, often, in the beginning, we might get paid. Detox usually takes, for alcohol, typically about 3 days. And we were getting paid that up until probably the last year or so under the Magellan contract.
So you would transfer people, would be your goal is to get them into other programs, right?
If they had any interest and we believe that they would seek treatment, we have patients that are quite clear with us that they have no intent. For the majority of the patients, there's probably good reason that 47 states don't have it.
But then all of us are paying for that because the hospital is eventually eating that. All of you had, Sara, you talked about the payments. Do you have trouble getting people to be able to be transferred? as far as if you have a difficult patient, do you have trouble in getting them to a different place? Maybe a nursing home, maybe something else.
I think I mentioned the example about the nursing home not wanting to take the Medicaid patient, and that was just a comment we had heard on Friday. You know, I think it probably depends on where they're needing to be transferred to, but I really don't have any, you know, data to sit here and tell you. I could tell you anecdotal stuff we're hearing. I think in the behavioral health arena, Kent could tell you, that's always been an issue. I don't know if it varies on different inpatient units or not, but I mean, I know that's, even under Magellan, that was hard to get people sent to the correct place.
Well, and I know that IME is aware of it because we've been referring people. It's just amazing the amount of, you know, examples that all of us could probably share with you. And, you know, I'll let others ask.
We have 5 minutes. We can stretch it a little to 10. We've got 4 people requesting. Senator Taylor.
Thank you, Madam Chair. My first question, I guess, is for Sara. Is any of your 100-plus hospitals, is any of them telling you everything's just fine? Any of them? Just one?
I have not heard anybody say everything is just fine up to this point, but you know, we are 3 months in, but no, I haven't heard anybody say those comments.
Okay. And my next question is probably for all of you, but more for Tim than anyone. What is this doing to your private pay people? What's this doing to the rates that they're having to pay?
At this point, we have not increased any private rates.
You've not had to increase yet. That's good. Hospitals, same way?
I have not heard that we've increased private pay rates, no. I don't think that we would do that until we would have, you know, like I mentioned, our rates on one for the outpatient side haven't even been billed properly for 28 hospitals, just because the rates have been inaccurate. So, I mean, I don't think we would do anything like that until we would know, you know, our bottom line and what's really happened financially.
Okay. Same.
For the most part, our rates were decreased at the start of our fiscal year, which was January 1, which of course was several months before we went into the IME period, and then April 1 occurred. So no, we have not increased rates, and I would really not expect that we would. Nobody's expecting to get more reimbursement in the future from Medicaid to Medicare. Private payers, hard to say, and you know the expectation is that we are moving gradually into capitated payment, where we're paid a lump sum per month per patient to take care of everything that happens to them, and it's a very difficult thing to do financially. I mean, our experience so far is that it's very challenging.
Thank you, Madam Chair.
Senator, just on that note, I did hear from a nursing home in my area, not so much that the rates, private pay rates were affected, but she had a mix of Medicaid and private pay. She wasn't being paid. She had to borrow twice. She is thinking that she might have to close, and all of those private pay patients will have to seek, you know, a nursing home elsewhere as well. So that's how it affects a private pay patient. But you know, the question was about rate. Senator Bokum.
Thank you, Madam Chair. I'm depressed after your presentations. So Kent, maybe we could talk. Maybe you could come up to St. Luke's for some treatment. You used the word shocking in terms of the amount of additional labor you have to do with dealing with these companies. So earlier we learned that we talked a lot about the denial of payment, and the department said that when things were denied, that providers know what the denial, why they're denied, and kind of hearing that that's not actually true. We had a case, JoEllen talked about a case of somebody that was basically incomed out and continued to receive services. Then another example of somebody that qualified for services but no notification to the providers that they qualified. And then we talk about a merit group takes 3 days to find out if a service is authorized. I mean, I can't imagine trying to manage a business, and your customers are these beneficiaries. They need your help, and you don't know if they qualify. You don't know if they do qualify, whether they're going to get paid, and just the enormous headache out there. And so this is very, very frustrating to hear these stories today. The other thing I just mentioned, I've heard from some providers, and I really, really appreciate these providers that are here telling us their stories, maybe a little bit worried in the back of their minds about having to deal with these MCOs going forward and getting fair treatment from them going forward. I don't know if that came into anybody's mind. I've heard providers with that concern. And I just want to say to the MCOs here today, any kind of retaliation against providers for telling us what's going on with their business is going to be frowned upon greatly by me, and I assume by other people around this table that want to make sure that we get to the bottom of solving these problems of providers and their customers.
Thank you, Senator. Senator Garrett.
Thank you, Madam Chair. I just, excuse me, wanted to follow up. I think I understood what you said about the mental health patients not being reimbursed. Did you say they were not covered by your contract? The services that were not being, you're not being
uphold the decision made by the managed care company. I pointed out for years, my medical directors, I've had two, if they could hear the appeals, we would do very well, I'm sure. But my doctors don't get to decide the appeals, their doctors do. And managed care companies have to have a physician in order to deny paying for a given service. And so they contract with doctors. Magellan actually had two medical directors, and they did a lot of their appeals for them. And so, yeah, even the appeal process, most of the time we don't appeal because it's uphold the decision made by the managed care company. I pointed out for years, my medical directors, I've had two, if they could hear the appeals, we would do very well, I'm sure. But my doctors don't get to decide the appeals, their doctors do. And managed care companies have to have a physician in order to deny paying for a given service. And so they contract with doctors. Magellan actually had two medical directors, and they did a lot of their appeals for them. And so, yeah, even the appeal process, most of the time we don't appeal because it's very unlikely to win.
Senator Garrett, it sounds like you're going to create some legislation for us next session to take some corrective action.
Well, you know, there was a lawsuit in Minnesota years ago, and I believe it, well, I'm not going to say who it was against, but I'm pretty sure I know. But the decision, it was about the appeal process being unfair, and the decision was that there needed to be a panel of people to hear appeals, not a physician, but a panel of provider, or rather a panel that included at least some provider representation. I think that would be a lot more fair. Because what it is right now is, you know, one of my people, who may or may not even be a physician, is talking to a physician, and those are often very short conversations, including that you get hung up on sometimes. They'll say, I've heard all I need to hear, slam the phone down. It's unbelievable.
Thank you, Ken. All right, we have just two more senators, and we'll go quickly here. Senator Johnson. Okay.
I'll reserve my time.
You'll reserve time. Okay, Senator Whitver, our new member.
Thank you, Madam Chair. And I know we're late, so I'll make this quick. Just a quick question for Tim. You said you have over $3 million that is still outstanding. That's obviously a lot of money. Is that continuing to grow? Is that coming back down? Where are we at in the?
Pretty much after the last 2 months, it's been about the same at the end of each month.
What's your confidence that it's going to start coming down? I mean, we're new in the process. What's your confidence in that number starting to decrease?
At this point, At this point, I don't know whether it will or not.
Okay.
We're hoping it will.
Yeah.
And as we get a little better in the processing that might help a little also.
Well, obviously, that kind of money is devastating for the providers, and hopefully it's going to be addressed as soon as possible. I don't want to jump to any conclusions, so we'll wait and hear from the MCOs, but hopefully they can address this and solve that problem as soon as possible for you.
And one more question will sneak in here, Senator Yoakum.
So you heard the presentation by IME just a few minutes ago, and in their presentation, they said that medical and pharmacy payment claims, the average process time was 8.5 days. What % of your claims are processed within 8.5 days?
I would say none. I'm really not aware that anything, we're just now learning that period of time where we were under IME, we've got a pretty good sense of what happened there, and there were a lot of problems there with, they didn't even have coding loaded for some of the things that we sent bills for, so they deny them, and then you have to figure out, as was pointed out, case by case by case. If we've had any...
So the 8.5 days is not really an accurate reflection of what you all are experiencing?
It depends on what she meant. If she meant that they spend 8.5 days processing a claim, that may be true. But if there was any implication that we're receiving money in 8.5 days, I think, again, a lot of the providers are saying, I think you'd have to hunt to find a provider that says they're being paid timely.
Second thing, in the presentation, they also said that if a claim is denied, that the MCOs are telling you why. What I'm hearing all of you say is that that isn't happening, that you actually have to do some digging, and that you are now having to push additional staff resources into the denial system in order to get paid. Is that an accurate statement?
Mm-hmm.
Okay. Mm-hmm. Finally, I wanted to the hospitals. I don't know if you have collected the information yet, but when we passed the health and wellness plan a few years ago, one of the reasons why we did that was to reduce the number of people using the emergency room for health care, because it's the most expensive way to get your health care. What I want to know is if you have any information showing whether or not emergency room care has increased at all in the last 3 months compared to the same time maybe a year ago, before all this happened.
And that is something that the Hospital Association should be able to answer in the next couple months.
Okay, great.
Yep.
Because I really want to know whether or not we're seeing an uptick in emergency room care.
Through the IPOP information we collect, we would be able to.
Okay, great.
Yep.
Thank you, Madam Chair.
Excellent questions. Thank you all, the four of you, and thank you all providers who are out there and who have taken the time to come to this. We're going to take about a 30-minute break, and when we come back at 12:30, we'll hear from consumers and advocates, and then at 1:15, the MCOs and DHS and IME will provide some insight into some of these things, and then closing comments at 2:25. There are food trucks in the parking lot, I am told today, so if you want to grab a bite to eat, there is food available. See you at 12:30.